So again, welcome to those of you who have been regulars, and to those of you who are new. I'm so glad you came to this discussion. We're going to focus on tumor markers and molecular diagnostics today. And CISM's mission, part of the mission is to train different stakeholders, so that's what we're doing. And if you could hold the questions to the end of each section, and we'll do that by just having you type in the questions, and then I'll look at them and open up your microphone as we go along. So learning objectives for today, by the end of the session, you should have a better understanding of what tumor markers are, how they're used, why they're needed, some of the problems with them, some of the successes with them, a better understanding of molecular diagnostics. And I forgot to mention at the beginning, and Patty, I apologize. Patty and I are going to jointly do this session. Patty very graciously agreed to do this. Jane's calendar got full, and so Patty and I stepped in to take over this talk. So thank you so much, Patty, for doing this. Patty will be handling the molecular diagnostics section as well as the precision medicine section. So that's how we'll divide it up. I'll do tumor markers, and Patty will do the next two. We'll break after tumor markers for questions, and then we'll break at the end for questions for Patty. And you can ask questions of either of us as we move through. So tumor markers are molecules that indicate specific characteristics of a cancer. For example, whether or not a breast cancer cell is especially sensitive to estrogen, and about 75% of them are. It's something that you can find. The doctor, pathologist can find, are they ER/PR positive? That's a tumor marker. Or whether a melanoma cell has mutation in the BRAF gene. And that's a genomic marker, and about 50% of them do. So you can find markers in different places, and we'll talk about that a little bit more. Sometimes they're detected in blood, and sometimes in tissue. They're trying to get diagnosis into urine because that would be the easiest place to find them. It's been a bigger problem than they had hoped. They thought maybe 10 years ago that they would be able to move into detection in urine relatively quickly, but there are a lot of stumbling blocks to that, and they just haven't been able to make that move yet. So here are some of the places where tumor markers can be used. And again, biomarkers, this is one of those terms where it has a few terms and they're interchangeable. People might call it a biomarker. It can also be called a tumor marker. So you could hear people calling it different things, but it's the same thing, and it's a substance that's found in any of the body fluids and tissues, and it may indicate that cancer is present. But as we go through the talk, we'll find out why that's not always the case. So this arrow kind of shows where they're hoping to be able to use tumor markers, and early detection would be a place that a lot of people are trying to look at, because it would be so much better to be able to use this in an annual, is to have a blood or urine test that could detect cancer actually really early. It's being used today in diagnosis, therapy, and a little bit in response monitoring as well. And each of these areas have areas to grow and expand, and as new research moves in, all of these different categories will continue to grow. But each one of them provides a path to better care for patients. Each depends on new research and on tissue donation. And Dorothy, you had mentioned last time, where do advocates fit into this picture? And this is one of the places where they fit, is as we're designing clinical trials and correlative studies become a part of that trial, we get to look at what tumor marker are they looking at, and why are they looking at it, and how can we impact that? Are there some questions we can ask them about that? So we'll continue to mention that as we move through. We can also be involved in that consent form. helping people understand how important tissue donation is. Make sure that consent form is well written and understandable. We don't get to precision medicine without tissue donation. We just don't. So this is going to be more and more required. 5 years ago, mandatory was a word nobody ever wanted to say, but we're beginning to have more and more trials that are actually based around the correlative markers. So it is the future. So where are tumor markers? They can be found at surgery, when that initial surgery is done, or during a biopsy. Hopefully we'll get to more body fluid markers, blood and urine. And the hope is that they'll be able to help diagnose, treat, and monitor cancer. That's the real big hope for tumor markers. They also can be used to find out who responds to a drug, responders versus non-responders. There's some tumor markers that people are looking at, and they're going to continue to look for more and more all the time. It would be so nice to know before you give somebody a drug whether they're going to respond or not. You don't want to spend that person's quality of life and their dollars on a drug that's not going to help them, that they're not going to respond to. So it's a critical piece for patients and for providers. Also, who's going to have side effects? It's important to know if there's somebody that's going to have a side effect that's kind of outside what people are expecting. And so people are looking at tumor markers and pharmacogenomics around that area. And so again, as you're looking through how people are designing the correlative markers, those were some of the questions that you'll be looking at. Is this a marker for diagnosis, for treatment, for monitoring, for finding responders, for finding side effects? And one of the things that I've always said is, you know, why are you looking for one marker? Can you look for 6 markers? Can you look for more than one? So you always want to get as inclusive as you can and as wide as you can. So here are some of the places where tumor markers are found. And when I first started learning about tumor markers back when, it was pretty much focused on the proteome analysis. And it was proteomics, and most of the tumor markers were proteins. And that's still sort of the case. A lot of the markers are proteins, and you find them through a proteomic analysis. But more and more, you're finding genomic markers. And recently, they've moved in the microRNA expression level. Is it increased or decreased? And there's markers attached to the RNA. So people are looking at all of these areas for markers. This one's labeled genomic tumor markers, but actually it's multiple markers. We have hormone markers here, the ERPR. We also have protein, HER2 markers, and we've got some genomic basal markers as well. So breast cancers are now being divided into subtypes because of markers. So that ERPR positive or negative, you can see how that has expanded over the last several, well, probably 5 to 10 years. HER2 came next, basal came after that. There's going to be other ones besides this. And one thing I forgot to mention at the beginning of the talk, because this field is changing so much, when we get to the question section, if you know of some new work or something you'd like to share with everybody, be sure to do that, because these slides are as inclusive as I can get them, but things are changing really quickly. So please, the nice thing about advocates, training advocates, is we can learn from each other. So please share what you know as we go through the talk. Here's some real classic genomic markers for lung cancer. And you can see in 2003, we didn't know a whole lot. So within just, 11 short years, 11 is pretty short in the research realm, we've got a lot of good markers now for lung cancer. And you can see that KRAS has a big percentage of the markers, as well as EGFR. But look at all of those other ones. They're very tiny subgroups. But for a patient who has one of these markers, if a drug comes along that targets that, so much better than having a drug that is just for the general population. Probably a lot of these will end up being combination treatments, so that it targets the mutation here along with some other drug that will target other cells, because most of these are pretty heterogeneous. So we're moving through the field, and each cancer is a little bit different, which ones they find. So for lung cancer, there's been some real good progress. And that's important, because that was one of those cancers that was really tough to get that diagnosis. Here's another little snapshot of genomic markers. P53, we've known about that for a long, long time, but they're finally beginning to maybe use it as a marker. It is a deletion mutation, but it has an association with the high stage and with survival outcomes. So people are beginning to tie outcomes to the markers, and that's because we finally started collecting this information. And now that ASCO's got this huge database to collect all kinds of information, I know in 5 or 10 years this slide is going to look really, really populated, and that's a good thing. So EGFR and RB and HER2/neu, these are some genomic markers that people are basing treatment and prognosis on. So here's the classic kind of thing that most of us started understanding tumor markers with, was the proteomic ones. And the interesting thing about proteomic markers is that you've got a couple of them, like CEA153 or CEA, that show up in greater amounts in a whole bunch of different cancers. So if someone's doing, and that's why they're not usually used as screens in annuals, because it doesn't really give you anything. It could be any one of these cancers. It could be a normal condition. It could be an inflammation of the surrounding tissue. So we haven't gotten to that point where any of these can be measured in a small enough amount and a specific type amount to know what cancer it comes from. So they're better used at following a patient. So you get diagnosed, you have a treatment, and then they follow your marker to see if you're responding to the treatment. Hopefully one day it'll be used in screening and in diagnosis, but right now we're not quite there yet. But this is a good slide that shows you for each cancer some of the markers that we know of at this point, the proteomic markers. So here's some of the problems that are especially there for the proteomic ones. You can have false positives where you've got the marker, but there's no cancer. And that's really disturbing for both the patient and the doctor. So it's real tough to get a false positive result. And so most people, most physicians, the medical profession, when they have a high marker, they will be doing other tests before there's any discussion of what that means, so that they put it into a whole clinical picture. Because that false positive, PSA's had a terrible track record with that, because just the surrounding prostate tissue has an inflammation from whatever. And it's not really prostate cancer, it's just an inflammation of the prostate. So it took a few years to unravel all of that, and I think that's the case for almost all of these markers. You get a little information and you put it into a formula, an algorithm of how it's going to be used, and you find out, well, it works here, but it doesn't work here, and here's an exception, and here's, you need this data. And so proteomic markers, they've gotten to the point kind of where they would like to do a panel of markers where you have 2 or 3 and put it together and get a signature. Just like molecular signatures, the tumor markers are kind of being used the same way, where you run more than one to get a better picture. False negatives are just as big a problem. When the marker is absent, but there is cancer, and in that case, you're just kind of out of luck. If you were counting on that value to be significant, so it really is one of those problems with proteomic tumor markers, and hopefully we'll move through that as quickly as we can. Here's an example of some RNA tumor markers and how they're captured on arrays. And so this is some of the newest work, is looking, in this case, there was prostate and melanoma, and they're looking actually at the RNA. So I think this is an exciting new addition, because they'll find new things, and maybe they'll be a little more reliable than some of the proteomic markers. I think this is a really helpful slide. The promise of tumor markers is that you can get a less invasive and earlier detection of cancer. If you look at that curve, those are cancer cells that are growing. And the higher you go, the bigger that cancer is and the longer it's been there. And you could see this blue mark here. That's the limit of detection by imaging. So when we have this huge discussion about mammography, whether it should be 40 or 50 or whatever, what I would really prefer that the discussion would focus on is that it's not really early detection. We're finding it here, but that tumor's been here for a long time. And if we could find a biomarker down here, it would be so much better than waiting until we could image it. This top one is when people can actually feel it or see it. There's clinical rope big enough that it can be observed without sophisticated imaging. But our detection methods are pretty poor. That we've got a cancer that's been there maybe 10, 20 years before we can image it. And so that's the hope of tumor markers, that we will find it here or even lower. If we can find it way, way, way down here, that would be so much better. Then we really would have early detection. And we really could change the course of someone's treatment and possibly outcome. So I like this slide a lot because it shows where we sort of are and where we hope to go. So there are also markers that are called prognostic markers. And that's a marker that's going to tell your physician, the doctor, how aggressive the disease is. So say we have 2 patients, cancer, patient A and B, and they both have a biopsy, and you run a gene array, and one will show that, okay, there's no metastatic potential there. And they can get conservative therapy. So that's what a prognostic marker is. It's going to tell you how aggressive that disease is. A predictive marker is going to tell you what drugs are likely to work. So we have our 2 patients again, and we look for HER2 expression, and we find out, okay, this is HER2 positive, so they will respond to Herceptin, and patient A is HER2 negative, so we won't give them Herceptin. So that's a predictive marker, and it's telling the doctor which drugs to use. And so both are important pieces of information. And here are some of the cautions again. We talked a little bit about the cautions with the proteomics and how we had false and negative positives and false negatives. But with all the tumor markers, they have to be reliable. And that means you have to provide consistent results wherever you go. No matter where someone goes across this country, that marker, once it's measured, is going to be measured correctly. And we've talked about this a little bit in other discussions, that part of that is based on how that tissue was collected. And this is whether it's tissue or blood or urine, how it's collected, how it's processed, and how it's analyzed has to be standardized. It has to be standardized using best practices. And unfortunately, in today's world, there are no mandates that this has to be done. For clinical lab results, it's mandated. You have to work in a CLIA lab, and you have to do this, that, and the next thing. But for collecting tissue and biomarkers, that isn't mandated, and it's up to each site to do it based on guidelines that the NCI issues, and some people follow them, and unfortunately some people don't. People are working really, really hard to make that happen. And it's not only at the clinical end, but it's also at the research end. So if you're looking at a trial that's being designed and they're going to collect correlative markers, one of the first things you would want to say is, will they all be tested in a central lab? Will all the sites send those samples to one place? And will that one place be a CLIA lab where everything is standardized? Because if it's not, then site A and site B and site C and site D, they'll all have their own test brew, and they'll all do it differently, and you've got apples and oranges in no time at all. So that's one of the critical questions you would ask as an advocate, is to make sure that you've got central processing, and this is not much of a problem anymore through the cooperative groups, through the network groups, because they have learned this lesson. So you're just kind of checking to make sure that it's happening. This is more for some of the smaller trials that are held at sites that have maybe 1 or 2 or 3 sites. I think the networks and the NCI has pretty much made it real clear that that's what they're looking for. So the VALID, Patty will be talking about the molecular diagnostics, how to measure and are those tests validated. So not only the marker has to be reliable and valid, but the test has to be reliable and valid. And it has to be of clinical importance so that you know that value will change treatment. Just having a name and a number isn't really helpful. So that's another thing we can ask is kind of a so what question. Well, I'm glad you're finding this, but so what? How is this going to change that person's care? Is it going to change their treatment? Is it going to change their outcome? So those are all questions we would be asking as we're looking at these new trials being designed and tumor marker explorations going on. Here's an example of some ASCO breast cancer guidelines. And these are always changing. I mean, because as new tumor markers are found and tested and validated in clinical trials, then they put out new guidelines. But there are some really, this one's hard to read. So let's move over to the lung cancer one, which is a little bit clearer. But really very specific flow charts for oncologists to say, okay, if you've got this marker, then we're going to do that, and if you have this marker, we're going to do this. And it moves you through a course of care based on markers. And this was pretty unheard of 10 years ago. And so we keep moving through this, and we'll begin to have more and more guidelines and charts and flow charts like this as we move further into the exploration and discovery and validation phase for markers. So I put these questions for your doctor up just because they're sort of reminders that these are going to end up with a patient and a doctor in an office. So as we're finding new markers, all of these things have to have a relationship to that patient. And so if people come to you and they want to know what questions they should be asking, here they are. They're on our website. You can get them there. You've got them on the slides. But it is important that people ask these, you know, how are these tests performed? How often should I have them? I don't know how many of you have had markers. I've never had markers done, but I was stage 2 and have never recurred. So I didn't have to go to the next phase of more treatment or metastatic treatment or care, and a lot of markers are used in that way, for breast cancer anyways. For other cancers, please share whatever you know. If you had markers that have been used in your treatment course, what they were, how they worked, were there problems with them, let us know. So here's the bottom line with tumor markers. The huge hope is that we really can get to better early detection. And if you look back at that, remember that slide of the curve where it's pretty late and then you can't see anything, and a biomarker could maybe make a difference. That's the big hope. We also want to determine if targeted therapy is possible. So if you remember back at the lung cancer, a KRAS or EGFR, was there a mutation? Was there a genomic marker there that could lead to a targeted therapy? Again, determine who may or may not respond to a drug, and that's really important for that person and that doctor. And actually all of medical care, as dollars get more scarce, we don't want to be over-treating or under-treating anybody. And also determine who may have serious side effects. So those are all some of the potential advantages. But there are disadvantages, and right now we're stuck we're moving through this area, and there's still lack of reliability. Some of that is measurement, some of that is collection, processing, some of that's the marker itself. It's just not the best marker. There are two ways you can get a tumor marker. The tumor itself could put out substances, or the surrounding tissue could put out tumor markers. And if it's the surrounding tissue, then that tissue could have inflammation for some reason that has nothing to do with cancer, but it's pouring out tumor markers. And somebody is going to measure those and think, okay, now what's going on? And so that's where you have to have a whole picture, a whole range of tests to know that this may not be cancer. It's a tissue-specific tumor marker rather than a cancer cell-specific tumor marker. So all of that is in play. So we have some overdiagnosis from false positives, or identification of cancers that would resolve without treatment. And PSA kind of falls in that category as well, where now there's a much bigger watch and wait program in place, so that just having an elevated PSA may be a very, very, very slow growing cancer that's never going to kill that person, but having intervention, having surgery, having treatment will cause quality of life issues that just aren't worth doing. So how do you figure that out? That's still a huge problem for an awful lot of men and an awful lot of doctors. And that's just one example. There are lots of other markers that are falling into that category, where you're just not sure what it means and when should you take action and when shouldn't you. It all leads to unwarranted anxiety. So we're sort of in that place of medical knowledge where we know some, but we don't know enough to really help every person every time. But we are getting better, and it is the future, and it is the hope. It is the promise. So in summary, the tumor markers are there to determine is there a probability of cancer. It can give you a glimpse, a snapshot, an idea. Maybe there is. And if you do panels, maybe you've got a little bit better idea. Maybe you do some imaging tests. It can tell you the severity of the tumor, and that would be some of the genomic ones, like P53 or HER2/neu. Some of these will tell you how aggressive a cancer should be treated. It can also give you the prognosis of the disease. If you remember back to that array slide where somebody may need really aggressive treatment based on the tumor marker that was found. It has been tied through outcome data to have a tougher prognosis. It can also help with tumor burden, and that's how a lot of these markers are being used today. Somebody has treatment, it could be surgery, it could be chemo, and then they look at the marker to see if it's dropped. And they may measure that marker every month or every 6 months to see if it stays down, because it is measuring tumor burden. And if that goes up, then that cancer is growing again. So it's good in metastatic cases. In cases where they can't get to the tumor, they can use chemo or radiation and hope to knock down that tumor burden. So it's another place where we can really use tumor markers, treatment response, and side effects again. So that's kind of the summary. I'm going to look to see if we've got any questions. So Jack, can you talk a little bit about circulating tumor cells, CDCs, as a reliable tumor marker in blood tests? Sorry, I'm connected remotely via my iPad, which has a microphone that isn't working. So Jack, I won't bother. This is Jack Wayland. I'm muting you. And circulating tumor cells is one of those areas that people have been looking at for like 20 years. And it's getting better. 20 years ago, when I was at UCSF, people had kind of thrown up their hands and said, no, we're never going to be able to tell whether this cell or that cell matters. But the capturing, the screening, the spectroscopy has gotten better. And so how we find those, and then they can put some of these tumor cells and run the next test on it to see, are these actively growing or are these dormant cells that are just floating around? And so that's another one of those questions that they're asking. How many are they missing? How many are they capturing? I think we're a lot farther down that road. We're doing a lot better at capturing a correct amount and knowing what that means. But are they dormant or are they active? We're active. We're working on that. And there are other tests that they're doing to determine which one of those, because there are some dormant cells there, and you can capture them. They're just out there floating, but they're never going to attach to anything or start growing. And that's some of those dormant cells. They don't know why they're there. They don't know if they ever will become undormant. So I think that this is an area that needs a lot more work. If anybody knows any more information on this, please type it in. Patty, do you know anything beyond that?
Yeah, so I can chime in on there. I think the technology has outrun the clinical utility at this one. I think when you find something, you don't know quite what to do with it, and they're going for circulating tumor cells as well as circulating DNA. But there was a recent publication that Francis Collins tweeted about that, is looking at, because you said, just a random circulating tumor cell might never cause anything, and would you really jump on that? And they're looking at devices maybe that are scaffoldings that, cells migrate to. So these are the tumor cells that would migrate somewhere and embed themselves in something, and can they detect those early by using some device type of thing? So I think that they're looking at more utility-based circulating information, but I think the technology has far outdone the clinical utility part of this one.
Yeah. So the last that I had read is that they were trying to determine which of those cells were potentially actively growing, and they were putting them on some media, or there was some way to tell which ones were dormant and which ones weren't. And I don't know where that research ended up. I know the spectrometry part of it is much, much better, that they're, like you said, the technology is there. They can find them now. And they can pretty much tell you how many are there on a pretty reliable basis. But what that means and whether it's tied to prognosis, they don't know that yet.
Yeah, and some are looking for, mutations that are tied to cancer, but that still doesn't tell you whether it's going to embed somewhere, or the epigenetic changes that are tied to cancer, so they know what kind of cell they're looking at, type of thing. But I don't think any of that is for clinical use yet.
Right. So here's a question from Jack Ayala. Maybe you want to bring up NCI's MATCH study, which uses markers rather than type of cancer. And that's really true. We talked about that, I think, one or two talks back, where there are actually studies now designed specifically around markers rather than type of cancer, and that really is exciting. And so you're right, Jack. That's this area is really moving quickly. There can also be multiple tumor markers on a given cell, and that's true as well. And again, it's whether these are tissue-specific or cancer-specific. They're also beginning to find that with immunotherapy, there's antigen tumor markers, and that's tossed a whole new hat into the ring. Which one of these are meaningful? So you can have an antigen marker, you can have a hormone marker, and you can have a genomic marker. And when you put that picture together, and you can have a proteomic marker. So you're right. It's there's a whole big area here that's moving really, I think, steadily at least. So Jack has an example. So we talked about that one. This is Jack Whalen. Some tumor markers can be detected early, indicating possibility of disease. When do we decide to start treatment? When symptomatic, when disease progression is underway? So that's...
I don't think they know.
Yeah,
I once heard the phrase that we are now treating risk instead of treating disease. So I think we have to be really, really careful.
And I think that's a perfect summary. And Angelina Jolie is an example of that, who someone underwent treatment based on mutations in a BRCA gene. And so she chose, that was a risk assessment. You know, she chose to have double mastectomy so that she would never have to think about it again, in her mind, in her head anyways, that she had treated it. So I think you're right that it's going to take us a long time once we even find those tumor markers back on that graph again, where it's in that latent phase when we find those markers. How reliable are they? How sure are we that it's a tumor that would have progressed to the point where it would have made a difference in that person's outcome? Those are all questions that, you know, are going to slowly evolve. And I think the choices are going to be individual for people. How much risk are they willing to undertake? I think there's a few that we may find that are a little more black and white, and that would be, you know, a nice case. But I think a lot of them are going to be exactly like you suggested, that it's going to be a risk assessment. But at least if you know that they're there, then you can either boost the imaging or boost the exams, or you could do a little more active surveillance, I guess is what they call it in the prostate world.
Yeah, and I think too, like that graph only had one instance of how the cancer is growing, but we know that some cancers grow really, really fast. So if you caught something early enough cancer that you knew typically grew really, really fast, you might do something right away. If you had one that you could wait, see what that marker is doing, you would wait. And if you have one that grows really slow, that's where I think we're really not sure what to do because we don't know if that tumor will ever become anything clinically significant. So I think that there's a lot of unknowns in there. It's hard to tell.
Yeah, and with some of this epigenetic treatment or immunotherapy, where there are hopefully some treatments that aren't as drastic, that we may be seeing more things like that, whether there'll be vaccines, whether there'll be something. As we progress through and begin to find those, then research will have to catch up in those areas to say, what are we going to do with it? Now that we know that it's there, what are we going to do with it? And that'll absolutely bring new areas of research up. And so here's Dorothy. Good idea. Thank you, Dorothy. Jack, yeah, Jack, you're muted. So I'm going to, so
Well, we'll
Jack,
come back to questions as well at the end.
okay.
So.
I just unmuted Jack Ayala. Are there any other questions you wanted to ask?
No, you asked both of mine, and if I type in another, you're welcome to say it as well.
Okay, great.
She did a good job, huh?
Sounds good. Okay, go ahead, Patty.
Okay, so we're going to go into molecular diagnostics now, but I think it really dovetails a lot with what Peggy just said. So Peggy told you, the clinical part of the, tumor markers and, why we're doing them. And I'm going to go over a little bit about the testing that's done. And there's going to be a lot of overlap, so I'll try to go fast through those sessions. But so, how are these tumor markers detected? And that's what molecular diagnostics are. They're the commercialization of tests that are used to reliably detect these tumor markers. So I kind of went all the way back to, I think Peggy has to stop moving her thing before I can move. Are you moving your thing? There. I could see your little cursor moving on the other side.
Gotcha.
I think we can't both be doing anything. So molecular diagnostics fits in the whole in vitro diagnostic testing world. So that's the world where when you take something out of the body and then you do something with it and test it. This is different than an imaging test, which is, your whole body testing, which is in vivo. This is outside, where I see actually molecular diagnostics actually moving into the in vivo world, but not quite yet. But they fit into this in vitro diagnostic testing world. And molecular diagnostics is kind of the new kid on the block and only has been around about 25 years or so, whereas the clinical chemistry, microbiology, and all of those have been around quite a few years. And Peggy and I have a lot of experience with the microbiology part of the story and infectious disease. So if you look at, what are molecular diagnostic tests, and these are tests that assess a person's health at the molecular level by measuring DNA, RNA, and proteins. And these are components that are shed or sloughed off tumor cells or part of the tumor cell that has been removed. Or like I really like Peggy's thing, yeah, if we could have a urine test, wouldn't that be awesome? And these tests provide very specific information about abnormalities. So if you look at, where you're going in the body, you can have cancer cells, you can have tissue that comes out of your body. You can also, molecular diagnostics is, oncology is one area that is in molecular diagnostics. And another area that I'm actually more familiar with is in infectious disease diagnosis. I actually have a whole lecture on infectious disease diagnosis by molecular diagnostics. So if you ever want to hear that, I'd be happy to tell you. But, those are the areas that are most commonly used by molecular diagnostics. And so in the cancer world, it'll inform you about the person and, the things that it can tell you that Peggy has gone over too is the predisposition to have a disease, whether you have a specific disease, and then maybe if you're likely to respond to a specific treatment for a specific disease. So these are some of the things that you could get from a molecular diagnostic test. And so I wanted to go over this again. So Peggy showed you a little rendition of genes, DNA, RNA, and protein, but I think it's really important for us as advocates to understand the whole process of it so that we know the benefits and limitations of the different molecules that we're detecting. So everybody knows that DNA is the cell, and it is actually translated into RNA. So RNA is a direct copy of the DNA. And then the RNA is transcribed into proteins, and proteins are actually the workhorse, and those are the ones that give us our phenotype, and so they're the ones that are causing all the problems within our cancer cells. So if you have a mutation in your DNA that doesn't cause a mutation in your protein that affects your cells, you'll never see it. And so, it's kind of like, so the further back you go from the protein, the more inferences you have to make about the about what's happening, and I think we're finding that out now. The BRCA genes have been around 20 years, and we have over 2,000 variants of unknown significance that we have no idea if they're doing anything or not to that protein at the end and causing you to be predisposed to disease. So I think as advocates, we really should know what this process is and know the benefits and limitations of each. And RNA is the intermediate to all of this DNA to protein thing, and there's actually two different kinds of RNA. There's the entire complementary RNA, that's the complementary DNA, that's the entire thing with introns and exons. So your exons contain the protein coding sequence, and your introns, previously identified as junk DNA, is no longer junk DNA because there's a lot of information in there, but it's not part of the protein. And then that is spliced into something of just exons that's translated into, oh, I've got my translated and transcribed backwards, but translated into protein. So, and then it's the protein. So just when I go over some of the next-gen sequencing, that'll become more appropriate. So yeah. So my transcribed and translated got switched. I don't know how I switched those, but your DNA is transcribed into RNA, and your RNA is translated into protein. So some people might not be interested in that, but I kind of am. So molecular diagnostics today, so over the past 5 years or 10 years or 20 years, I think every day, I think it's improved. It's faster, cheaper, it is more complex, and they are more meaningful tests. And I think that, every day you see new things coming out. And they're beginning to be used as standard practice. You're really seeing them used in standardized labs. A lot of patients get their tumors tested for all of these markers, and even now you can do mail order. You can get your whole genome sequenced by mail order. So I think that these tests are here to stay, and they're getting better and better, and it's a really fast moving field right now. So there's a lot of different types of molecular diagnostic tests. So some tests check for genetic information, and I'm just going to go over 3 bullets, but there's really probably like a gazillion bullets that you could put here. So the genetic information tests have changed over time as well. It used to be that you would just test for one gene, and now you test for panels of genes, even in your sequencing for risk. And now we've gone to the whole genome analysis. So we've got the next-gen sequencing, we're looking at the whole genome. So there's all these different variations of test, and now with the new Supreme Court ruling, there's a lot more companies in the game. Myriad Genetics, of course, did the BRCA testing for years and years, but now many are doing it. The whole genome sequencing, many have jumped on that bandwagon. You have Pathway Genomics, GenDx. They have thousands of companies basically that are doing these genetic tests now. So you can easily get these tests done now. And Peggy went over the prognostic versus predictive test, and I think this is also very important when we look at things. I'm actually looking at a concept now, and it's a great prognostic marker of aggressive disease, but is it really going to be predictive of a treatment outcome if you treat a certain way? And I think that that's a hard concept because, it's just a hard concept. But prognostic is that information on the outcome, whether it's more aggressive, less aggressive, regardless of whatever treatment. Predictive is the information on outcome is based on a treatment like the HER2. You treat with Herceptin, you're going to have a good outcome. Whereas HER2 by itself is a prognostic indicator for aggressive disease. So it goes both ways. So one marker can be both prognostic and predictive. And then nowadays, so now with all this testing and all this need for testing, and especially with like the MATCH trial, the lung map trial, the alchemist trial, all these trials now that are the treatment is directly linked with a molecular test of some kind. Companies are now co-developing companion diagnostics with their drugs now, because to get FDA approval, a lot of times you have to have a test to go along with your selected population so that you can get FDA approval on both at the same time. And I was just on, my Genome Web, alert thing. And of course, there are tests and complementary and companion tests being approved every day. So I think that, on our specific disease sites that we concentrate on, it's good to keep up with all of these different approvals that are coming down all the time, every day. And Peggy went over this, so I won't go over this very much, but how good is a test? And I think this is really important. I work in a lab, and lab tests do have variability, and variability is always going to be there, and you can't get around it. So an ideal test is 100% sensitive and 100% specific. This will never happen in my lifetime, I don't think. But they strive for that, and so you really want to know how specific it is and how sensitive it is. But 100% specific means that, so I've got some little things down here. So a good test should be almost 100% specific, so that it should never say that there is cancer when there isn't. And false positives from non-specific tests can lead to more tests. So it is important because it can lead to more tests or over-treatment or under-treatment of things. So 100% sensitive means that all positive tests will test positive, and there'll be no false negatives. So you will never get a negative if they're positive. 100% specific is that all negatives test negative and there's no false positives. So depending on what you're doing and your comfort level with false positive or false negative is where you want your test to be. So if you're willing to miss a few to, you just have to do those trade-offs when they develop tests. So I usually tend to look and see what their specificity and sensitivity are on different tests. Most people don't, but it's really important to know what that means. So that's why some people get retested as well. So Peggy also went over this on molecular diagnostic use is done in all different stages, from risk management, screening, all the way through post-therapy, during therapy, post-therapy, and surveillance. And these are some of the questions that are answered by molecular test. And I think in the surveillance area is really interesting and critical. I think that's where a lot of the tumor markers like PSA and the different breast cancer tumor markers are done, but there's not a lot of data behind it on whether they're useful or not. And I think clinical utility is where we really need to focus. And so there's actually some PCORI grants out there looking at prostate, colorectal, and breast cancer surveillance, seeing what's done in the right now, what's actually being done, because nobody really follows the guidelines, and then see what the risk benefits are of screening or not screening with these different tests. And so these are some of the tests that you can actually run in those different areas. I guess in staging I didn't have a lot of testing, but I guess that's where you would get a lot of the basic biomarker tests done, but I didn't put anything down there. But this is just kind of an idea of where the different circulating tumor cells, what might be done, or the circulating DNA, PSA, those type of things, as well as your therapy selection with your different genes. And Peggy showed that short list. Well, I found 2 really good references on molecular diagnostics, so if you would like them, I'll give them to Peggy and she can send them out. But there's a nice table in one of them that has actually a multitude of genes covering 28 pathways. So I think we've come a long way that each have a putative or potential or therapy to go with them. So I think we're coming really far in that therapeutic selection area for our molecular tests. So how are things changing? So the old way of doing things is, just taking the patient tumor sample and doing pathology, and that's a very anatomical way where you look at the morphology of the cells and the size and the structure of the cells. You do some staining of the cells, but you really look under a microscope at things. And so how are things changing? Well, now you take the patient tumor sample, you might take blood sample, and you do proteomics and genomics of it. But I'm adding in that you're also going to do the pathology as well. I think that some of the newer papers coming out saying, we do have these agnostic trials on just using the genomic data or proteomic data to drive treatment, but there, are some differences between the different tumor types. So there was a recent paper published on that where, just because you have the mutation in this one cancer doesn't mean in this other cancer it'll respond the same way to the drug. So I think pathology is still relevant as we move into this genomic and molecular diagnostic era. Putting it in my plug for pathologists here, but they do a lot. So pathology does a lot of the molecular testing. And now I was just sitting at a table with a bioinformatic pathologist or something, and I was like, that's a very new field based on all these molecular testing being done in the pathology lab. So now I'm going to go over just a few, I guess it's just one different way. I get to that soon. But these are just some examples of what can be done and what can be looked at. So for gene arrays, you can find cancer with specific gene expression patterns. So this is looking at RNA expression. You can look at common variations in your DNA, different mutations, and those are looking at the DNA. And then you can find gene patterns that might indicate potential metastases. So when you look at just individual changes, sometimes you don't see anything, but when you look at patterns, you can see something of more in depth. So these are just some ways that you can use a gene array. And I really like this figure from this one reference, the Nature Reviews. I saw this at a recent meeting, and then I found it in Nature Reviews, and I thought this was really good. So, and I had asked the question once, so what is next-gen sequencing? Because everybody uses that term very loosely and just say, oh, we're doing next-gen sequencing. Well, what exactly are you doing? I really want to know. And so this is a really good figure. So these are next-gen sequencing strategies. You can have whole genome sequencing where you're sequencing everything. For point mutations, you can look whole exome sequencing. I told you about exons and introns. This is just looking at the exons, the protein coding region, which is only 1% of the entire whole genome, because the whole genome looks at introns as well. So you're looking for different things there. You can PCR amplify just specific genes and look at just specific genes, and that's very detailed when you know what you're looking for. The transcriptome is the RNA, so that's the expression. So, are you getting RNA that's made into, or is your DNA being made into RNA, and then can you detect that RNA? And then you can take that RNA and you can just look at the exons of the RNA instead of all the RNA. So there are all of these different iterations of sequencing, and so always ask what exactly they are doing when they say next-gen sequencing. And so here is a slide with two very current breast cancer molecular tests. So the Oncotype DX analyzes the expression of 21 genes in estrogen receptor positive breast cancer and determines the likelihood that it will, so a recurrence score, whether it will come back or not. And therefore, if it's got a high recurrence score, you might want to do chemotherapy as well as hormonal therapy. And vice versa, if it's got a low score, then you may be able to forego chemotherapy and just do hormonal therapy. So this is the test that was in the news, and the headline was, I think, saving patients from doing chemo type of thing. So I think it's really well used in the clinics. It is used a lot in the clinics. Most people in support groups that I've been in have had this test done. So it's very highly used. The MammoPrint is another test that uses 70 genes that can be both ER positive and ER negative. I haven't seen that one used as much, but that is another one that's used. And both of these have enabled women to forego or get chemo if they need it, or forgo the chemo if they don't need it, which is kind of, you want that clinical utility piece in every test that you have and everything that you have done. And this slide is one that, there's tests out there, the lymphochip, that can identify a good prognosis from a poor prognosis in lymphoma. And then in lung cancer, you have, so this is probably a really old slide, chip that can identify the different lung cancers. And now lung cancer, like what Peggy has had in her slide with all of the gene mutations that have come up in lung cancer, I think it's just really different. And I thought back in the day, we thought this was really cool to identify all the different types of lung cancer, but now it's like with the gene mutations, it's really aided in the treatment of lung cancer. So I think it's really progressed through there. Dramatically, but these are all really good molecular tests. But one of the things about molecular test is, like I told you about the bioinformaticist that's a pathologist, which you would never see before, it's about integrating a lot of these different disciplines into this clinical translation piece. And so, you start with a molecular biologist who develops a test. You need people to develop that test platform. The bioinformatics and the software development of some of these tests is enormous, especially when you're talking about the genomics. You really need to have a good team together and identify people. And, there's absolutely a lack of funding in this area for people to go into this area. So, and this is probably where a big bottleneck is in a lot of the molecular testing. And then genetic counselors, we're doing so many more sequencing and de novo sequencing for risk, and genetic counselors are so important. And then just the electronic health records and the electronic of all of this data coming in. So this is considered big data when you start sequencing and having all of this information to deal with on each patient. Can you link it to their medical record, and then can you do anything with it in the future? So I think a lot of things are dealing with how are we going to integrate all of these things together in the clinic so that it can benefit patients. But there's a great promise for molecular diagnostics. It's faster, less expensive drug development. It's personalized. I think we're going to have more drugs that are effective because we can better select the population. And so this really feeds into the whole personalized and precision medicine initiative that's going on in everything. And it is a growing field. So right now, in vitro diagnostics globally is a huge field. And like I said before, a lot of it is in infectious disease as well as cancer. But the molecular diagnostics as part of the in vitro diagnostics is a piece of the pie, but that piece of the pie is growing at a bigger rate than all the other pieces of the pie. And I think it's going to grow even faster than 12%, actually. And so I think that we see nothing but things getting bigger in the future. And this translates into better information for your doctor. So prognostic tests will give us information about the likely course of your cancer, whether it's aggressive or not aggressive. And those are really important when you choose treatment options and what you're going to do. And whether you're going to have an aggressive treatment or not. Predictive tests can go even a step further, and they can indicate which drug you should be taking or not taking. So a goal is that new targeted therapies will be developed for specific molecular diagnostics that will provide information about likely drugs. And I'm thinking that they're going to be co-developed more often now than not, because you just have to co-develop them now. And many of our precision medicine trials are using this now and are directing patients and which arm they will be in. But we also, so I have a note down, what does it mean, but I don't know what it means. So there are still some challenges for clinical translation. So and this was a table in one of the papers, the Nature Review paper that I cited at the bottom. So for the molecular diagnostics, you know, the choice of the assay, the tissue quality, we know there's heterogeneity in the tissue, whether there's tumor content or not, turnaround time if you're waiting for a treatment, it really has to be timely, you know, the validity of the test and all of that is important, bioinformatic information. But I think the real thing is the clinical implementation of it and that it's clinically valid and it's useful information. That's what my "what does it mean" note means, because I think that's where the rubber hits the road. I think that, you know, we have to kind of make sure, because a lot of times projects are set up as a technology challenge, and we have to always ask that clinical question, well, what does it mean to the patient? So if this is successful and this identifies this, so what? Will it benefit patients? How will you use that in the clinic to benefit patients? And I think we always have to ask that question, because I think you always have to have that in mind when you're developing molecular diagnostics or looking at these molecular markers in cancer. Well, what does it mean to the patient? If it doesn't mean anything to the patient, then should you spend $1,000 on a test that is really not clinically meaningful to the patient? So I think as patient advocates, that's where we can really be of help to the clinicians. So advantages is the general public is being sequenced right now. You know, maybe earlier diagnosis, more detailed information, more selected treatments, monitor the effect of your treatments. But there are disadvantages, you know, high cost, uneven reliability, need for proper tissue handling, and I would add, you know, clinical utility, lack of clinical utility of some of the information that you're getting. You're getting so much information that is not all clinically relevant. And so in summary, molecular diagnostics are tests that are used to assess tumors at the molecular level using the DNA, RNA, and proteins. And I think that there is a role for them, and they're going to become more and more. So we're going to do the precision medicine. It's only a couple of slides because there's a whole lecture on it that Carol did about 2 sessions ago that's really, really good, and I would highly recommend you listening to that when it's posted. I think she did a great job on that. And so tumor markers really are to help with this precision medicine world, and that not all patients are the same, and you can have favorable prognosis, unfavorable prognosis, and increased toxicity. I mean, I think that, you know, there's so many uses that we can use these tumor markers for in the future. And then, of course, the precision medicine promise. So I can't find my sheet, but I'll just wing it. So the precision medicine promise, and I think this is like the future, and really it's going to be driven by those diagnostic tests and the validation of all of these markers. And I think, you know, these 4 pockets are 4 pockets that I think that we forget about a lot of times, and I think we look at, oh, this is the benefit of this drug and these are the toxicities of these drugs, but I think I like these 4 buckets, and so can we put people in different buckets based on diagnostic tests and treatments where we know who's going to get benefit with no toxicity, that green group. We want everybody in that group. Some will get benefit with toxicity, and how much can we take, and can we know what that is, and we can make a judgment call on that. If we have markers and drugs where we have no benefit, no toxicity, you just wouldn't give the drug, as well as doing harm by no benefit plus toxicity would be really bad. So can we put people in these different buckets and treat every cancer patient appropriately? So, you know, doing the right drug to the right disease at the right time with the right dosage. That's the promise of precision medicine. And I once heard personalized medicine is actually so precision medicine is actually doing personalized medicine more precisely, and I think that's kind of the target here. So the bottom line is that you know, possibly precision medicine can limit the use of ineffective treatments, and more treatments will be effective with fewer side effects, lower health care costs, and better care for your patients. disadvantages is when there's no targeted treatments for some patients, which can be really really disheartening, and then they don't know where to go. And I think that's where we are in breast cancer. With triple negative breast cancer, people just don't know what to do. And higher individual cost, the drug companies are really taking advantage of it, and possible access issues because of that. So in summary, I think that precision medicine is here to stay, and it's a lofty goal, but I think we can achieve it. And getting that highly detailed information about the tumor and your health on the molecular level will really help that. So I think that's the end, and we can take questions now.